Hello and welcome. In this podcast from the NIHR, we'll be looking at psychosis and the potential benefits and harms of reducing the dose of antipsychotic medicines. During a psychotic episode, people lose some contact with reality. They might see, hear, or believe things that other people don't. Their thoughts, ideas, and speech may become fast and confusing. These symptoms can cause severe distress and change people's behavior. Antipsychotic medicines reduce the risk of psychotic episodes, and they're recommended for long-term use by people with schizophrenia or recurrent psychosis. But the medicines can have such unpleasant side effects that people prescribed these drugs may want to reduce or to stop them. Today, we're discussing an NIHR trial in which people were supported to gradually reduce their antipsychotic treatment. My name is Helen Saul, and I'm the Editor-in-Chief of the NIHR Evidence website. I have two guests with me today. Welcome first to author Joanna Moncrieff.
Thank you for having me. I'm a Professor of Critical and Social Psychiatry at the University College London, and I was the Chief Investigator for what was called the RADAR programme, Research into Antipsychotic Discontinuation and Reduction, which was funded by the NIHR, as I said.
Thank you. And Rachel Upthegrove.
Hi, thanks for inviting me. So, yes, my name is Rachel Upthegrove. I'm a Professor of Psychiatry and Youth Mental Health at the University of Birmingham and a consultant psychiatrist in early intervention and psychosis services, where I've worked for over 20 years.
Thank you. Rachel, could you outline for us the impact of recurrent psychosis on someone's life?
Psychosis in itself can be very impactful for people's function in terms of ability to maintain roles, jobs, relationships. And because the onset of the illness is between late teens and early 20s for the majority of people, this is a critical period for developing those social roles and jobs, relationships, place in society.
And you'd see antipsychotic drugs as an important part of treatment.
Coming from a background I do from early intervention, our aim has always been to reduce the impact of psychosis and reduce what we call the duration of untreated psychosis by intervening early after someone has made or had a first episode of psychosis. So antipsychotic medication we know is effective in 75 to 80% of people for treating an acute psychotic episode. And in early intervention service, that's part of psychological, social, peer support and other interventions, but as a very key part.
What about the side effects of these drugs, Rachel?
All medication or everything, every treatment would have potential side effects. So psychological interventions, social interventions, but also medication has potential side effects. In terms of antipsychotics, these can be broadly grouped into things that might affect what we call extrapyramidal side effects. So muscle stiffness, tremor, rigidity. The more sort of second generation antipsychotics might have a little bit more emphasis on other things like weight gain and sedation, and also can affect sort of hormone levels, so prolactin, so they can stop periods and cause other sort of prolactin related side effects. So that they do have a range of side effects that people want to avoid by getting dosing regimes right. And all medication has side effects that as a prescriber, you talk to your patient about and would be honest with them about potential for side effects as well as potential for benefits.
I just think it's important to emphasize they are really significant.
Yeah. And this is treating a significant illness. So I think
yes, of course.
Yeah.
Joanna, you led a trial called RADAR, exploring the impact of gradually reducing antipsychotic treatment. Before we discuss that work, perhaps you could tell us what previous research has shown.
So there have been lots of studies that have compared continuing with antipsychotic medication with coming off it and being given a placebo instead, or just coming off it altogether. And those studies generally show that people who come off the medication are more likely to have a relapse and end up in hospital. But one of the reasons for doing the RADAR study was that those studies have almost all taken people off antipsychotics very quickly And we know that there are withdrawal effects, including agitation and sleep problems. There's also possibly a link between withdrawal and psychosis itself, so that it may be that withdrawal increases the risk of having a psychotic relapse that's specifically related to the withdrawal process rather than the underlying condition.
So what approach did the RADAR study take, Joanna?
The trial was aimed at people who had recurrent episodes of psychosis or a diagnosis of schizophrenia. And what we did was identify them. We excluded people who were thought to have very, very severe risks of harming themselves or harming other people if they came off medication. But otherwise, our inclusion criteria were fairly broad. We recruited people from secondary care mental health services, and once people consented to join the study, then they had a baseline assessment, and then they were randomized either to continue on their current dose of medication more or less. People could make adjustments for side effects, obviously, but they were encouraged to stay on their current dose if they could, or they were randomized to have a gradual reduction of their medication, supported and overseen by their treating clinician. And people came into the trial on all sorts of different medication regimes, different sorts of antipsychotics, and different combinations of antipsychotics in some cases. So what we did was we drew up a schedule for each individual for a gradual reduction of their medication that their clinicians could follow. But we also emphasized that the reduction was meant to be flexible, and, people weren't to be forced to continue to reduce if they, were having a life crisis, or if the reduction was going badly and their symptoms were coming back. So it was meant to be flexible. And then people were followed up at 6 months, a year, and the main follow-up was at 2 years after randomization.
And what was happening at 2 years? What were your main findings?
What we found was that people who'd been randomized to reduction were more likely to relapse than people who were randomized to maintenance treatment. We defined relapse quite stringently. Our main relapse outcome was a readmission to hospital with a psychotic episode. So that was the result in terms of relapse, which was disappointing because we hoped that we could reduce the rate of relapse. I don't think we ever thought that there would be no relapses, but we hoped that by doing this gradual reduction process, we could at least have lower relapses than were seen in other maintenance studies. But in fact, the relapse rate was around about the same as in most maintenance studies, the readmission rate, the hospitalization rate anyway.
But your main outcome was social functioning. Could you explain what that means, please?
Social functioning really means how are people able to get on with their day-to-day lives? Are people able to go to work? Are people able to look after themselves, attend to their personal care, do their shopping and cooking? Are people able to get on with other people, both their close family members, but also members of the public? Are people able to take part in leisure activities as well as work activities? So that's what social functioning means.
And was there an improvement in social functioning with a reduction in antipsychotics?
We had hypothesized that maybe there might be an improvement in social functioning at our 2-year outcome, although I think we always thought that was a little bit optimistic. The Dutch study that we'd modeled the study on had only found the improvement in social functioning at their 7-year follow-up, in fact. But anyway, we looked at social functioning at 2 years. There was no improvement in the group who'd been randomized to reduction, but there was no detrimental effect either. There was no difference between people who had been randomized to reduction and people who'd been randomized to maintenance treatment in terms of their social functioning, or in terms of their symptom levels at follow-up, or their quality of life, or their medication side effects, even though they'd reduced their medication quite a bit. So that was a surprising finding, or their satisfaction levels, or any of the other outcomes that we looked at.
So what was your response to your own findings, Joanna? You said the increase in relapse was disappointing.
It was disappointing. As I say, I hoped that we could at least have reduced relapse rates a little bit. And I think it's, I think it's interesting and important to know that the sort of gradual reduction we did anyway, which was over about a year to 18 months, doesn't significantly reduce relapse rates. It's possible that doing reduction over a longer period might be better. So that was disappointing. I think it's also important to emphasize, though, that our study, like other studies, found that not everyone relapses. In fact, overall, there's an increased risk of relapse, but for each individual, it doesn't mean that each individual will relapse if they stop their medication. So the point of the RADAR study was always to provide information for people to make informed decisions about the risks and benefits of treatment. And so the RADAR study, along with other studies of antipsychotic reduction, does show that there's an increased risk, but not an inevitable risk of having a relapse. I should also mention that we, at the same time as publishing our the main paper detailing the quantitative results of the study, we published our qualitative study. In our qualitative study, we interviewed 23 people who'd been involved in the antipsychotic reduction program in detail. And we made a point of selecting people who'd had various outcomes, not just people who'd done well with reduction, but people who'd done badly with the reduction, people who'd relapsed, and people who hadn't been able to even make a reduction. And in that study, what was really interesting was that many of the people in the reduction group had felt a sense of empowerment through the process of reduction, even if it had not worked out well for them, and had come out in some cases thinking, okay, well, I've had a go. Now I know I've just got to stay on the medication. In some cases feeling, okay, maybe it didn't work out this time, but maybe if I did it more slowly or carefully in the future, it might be possible for it to work out. So I think that was also an important finding for me, that there was something about doing the trial and offering people the possibility of having a supported reduction with a clinician that benefited people.
Thank you. Rachel, how do these findings chime with your clinical experience?
Well, I think the first thing to say is Joanna sums it up very nicely, in that the study fits in what we already know, is that in a previous trial that if you reduce antipsychotic medication, there is a significantly increased risk of relapse. And previous trials have done that. So whenever we're talking with patients in a collaborative way about treatment options and treatment decisions, it is weighing up that evidence and balance of risk. So the risk of relapse for somebody might be very different than the risk of relapse for somebody else, given, past experience of psychosis and everyone's individual risk history, versus the side effects of medication. So this is what we do day to day. This is what prescribers, psychiatrists, nurse prescribers, allied health prescribers should be doing as part of good care anyway. Having that individual conversation about the risks of you reducing or stopping medication will be. And, particularly in my practice, this is something that we would do. So the trial, reinforces that evidence, that reducing antipsychotic medication contains with it a risk of relapse, in and of itself. Certainly one of the main, ways that we can prevent relapse is continuing, antipsychotic medication. I think that one of the things that we also need to be really, really cognizant of is there's also very clear evidence that for a certain percentage of people, every relapse carries with it a risk of treatment non-response. So 15 to 20% of people will have one episode of psychosis and never have another episode. 30% of people, 25% of 30% of people might develop treatment resistance, so difficult to treat symptoms from the first episode. And everybody else is in the middle. But this group in the middle, every episode a percentage of people don't recover fully. So there's risk in relapse. And it's just really important that in trials and in clinical practice, we are very, very clear with those risks of relapse. So it's the risk of social functioning, maintaining work, maintaining relationships, but also the risk of if we need to reinstigate treatment after a period off treatment, that it may not be as effective as it has been before. And so we just need to take the evidence from the RADAR trial in this context as reinforcing the risks of relapse. And certainly within the 2 years, not improving social functioning.
So I agree with Rachel that, relapse can have profound personal and social consequences. Some patients desperately want to avoid having a relapse and have had really bad experiences in the past, people who've had recurrent episodes. For some people, it is less significant. So I think, that is an individual thing. There isn't evidence that relapse in itself causes a bad outcome. The majority of studies actually show that people who've had a relapse overall get back to the level of functioning and level of symptoms that they were at before. There's nothing about having the relapse that makes the sort of condition worse, other than obviously the social and psychological consequences of it. And actually, we've been looking at data from the RADAR study on this as well. And people who've had a relapse don't do any worse in terms of their social functioning and symptom scores at the end of follow-up.
Clearly, there's ongoing debate about the specific harms of relapse. Rachel, what would you see as a research priority?
The real question that remains in my day-to-day practice and other people working with young people with first episode psychosis that we're seeing when they've had one episode, how do I know if I'm going to be in the 20% or, and is there any way of improving our individual prediction for what we need to do for this patient? And that wasn't what the RADAR study was designed to do. But I think to move ahead, we need to move from big trials of groups of people who perhaps already have a significant risk of relapse to understanding for me, with all of my risk factors, or my experience, is it a sensible, thing? Is there any evidence for an individual patient level that actually dose reduction or dose discontinuation is a sensible thing to think about?
Would you like to come in on this, Joanna?
People have been trying to do this for, decades and decades to identify people who might have a relapse and people who might not, whether that's, during medication reduction or just in general. And it's proved very, very difficult to identify. And again, we've been looking at this and not really found any strong predictors. And there are almost no studies that replicate any relapse predictors. So I think we need to accept that we can't predict who's going to have a relapse or not. And we should just assume that everyone has the same chances and go on that.
I would just come back on that a little bit, because I agree with Joanna that we've not been able to develop a tool that is clinically useful in terms of relapse prediction. On the other hand, we just haven't had the access to the size of the data we need to do accurate individual level prediction. So I think that there's still a challenge for our field in terms of using the harmonized outcomes, having sort of a collaborative approach so we can have access to that data. And I wouldn't say that that's ever going to be something we should give up on trying to do until we've given it as good as go as there have been in other branches of medicine or health with the same volume and scale of data.
Thank you, Rachel. Joanna, where do you see the next steps in research?
I'd like to see research that helps support patients to make informed decisions really about their treatment and be more involved in treatment decisions, particularly people who've had multiple episodes, because I think first episode services are quite good at engaging patients in these sort of discussions. But the trouble is often patients who've had a number of episodes just get left and everyone assumes they should just stay on medication forever. And And I think some of those people have really quite a poor quality of life because of all the side effects that we've been talking about.
Thank you. And Rachel, what would your take-home message be?
Certainly agree with the last point in terms of making sure and advocating for best care for people with severe mental illness throughout their lives and throughout their the duration of their illness, and it comes back to what this trial and other trials have shown is that because of that risk of relapse, when we're reducing doses and discontinuing doses of medication, this really does need to be an engaged individual discussion with a trusted prescriber who can help people weigh up their risk of relapse and work with them to find the optimum dose of medication that will help with symptoms and reduce the symptom side effect profile. And that's just good medicine, right? That's what we should be doing with our patients. They're saying these medications work, they have side effects. What is the best thing that we can do with you? Because if we don't have that conversation, patients don't take the advice that we're giving them, and they don't take the medication, and they will stop on their own and stop suddenly and stop because that interaction with your prescriber is very important. And that individual choice based on the evidence of risk, it is something that we should be doing. I think a take-home message is that relapse contains risk, and that varies by individual to individual. For some people, that risk includes serious self-harm, suicidality, or risk of significant social functioning and social, impact on their social functioning. And so for every individual patient, we need to have an informed conversation with people before they reduce medication or stop medication, but amongst everything else, work with patients in a trusted relationship around their prescribing choices.
Thank you, Rachel. And a final word from you, Joanna?
Well, yes. I mean, I would go along with a lot of that. I do agree. There are some people who, the risks that they may run if they have a relapse are very high, but there are many people who where that's not such a consideration, who I think really deserve to be given the opportunity to try and reduce their medication if that's what they want to, as long as they are informed of the risks and have all the information, both from RADAR and from other evidence about the pros and cons of that process, and as long as they, have clinical support during it.
Thank you, Joanna Moncrieff and Rachel Upthegrove, for joining me today and sharing your views. This is an episode of the NIHR podcast. I'm Helen Saul, and thank you for listening. If you have thoughts or comments on this or any other episode, please contact us at evidence@nihr.ac.uk, and do visit our website, which is evidence.nihr.ac.uk.